Good evening, everyone. I am Dr. Shailesh Gupta. I am a consultant in pediatric and robotic surgery from Max Patparganj and Vaishali, Delhi NCR. So today I am going to discuss about GERD and hiatal hernia part 1. This lecture, GERD and hiatal hernia, divided into three parts. Today I am going to discuss part 1. This is a very important topic. This can come in your theory and also can be asked in Viva. And as a clinical and as a surgical clinician, gastroesophageal reflux disease is one of the commonest disease you're going to encounter in your clinics, right? So this chapter I made from Sebastian because esophagus is given best in the Sebastian. To start with, this will be the flow of lecture. So I simplify the text. There will be some MCQs in the form of pre-test, and the answer will be given in the post-test, right? So what I'm going to teach you, I'm going to teach you about the pathophysiology, clinical feature, which will include typical clinical features and some atypical extraesophageal clinical feature. I'm going to discuss about how we're going to evaluate the disease, right? So in which we're going to discuss about ambulatory pH and impedance monitoring in detail. We're going to discuss about endoscopy role in GERD and also about barium study. Just remember that we discussed manometry in detail in the previous lecture. So this time I'm going to discuss about pH and impedance manometry in detail, right? So coming on, starting the lecture. So first is pathophysiology, right? So these are the pre-test. What is the distinction between physiological reflux, that is GER, and pathological reflux GERD based on? So physiological pathological में क्या difference है, distinction कैसे हम करते हैं? It depends on size of hiatal hernia. It depends on presence or absence of mucosal damage in the esophagus. Its difference lies in the LES pressure measurement or total amount of esophageal acid exposure. Patient symptoms gives a difference between the physiological and the pathological reflux. Next question is, which type of hiatal hernia is the most common? Type 1, type 2, type 3, and type 4. So I would request the student to please write their answer in the chat box. Question number 3, what is the primary reason for hiatal hernias being often associated with GERD? So hiatal hernia के अंदर reflux disease क्यों होती है? तो presence of mucosal damage in the esophagus, abnormal anatomy compromising the efficacy of the LES, increase intra-abdominal pressure, or hypotensive LES. So in out of these four, what is associated with hiatal hernia that is causing the gastroesophageal reflux disease, right? Question number 4, what is the role of sling fiber of gastric cardia in the lower esophageal sphincter surrounding the esophagus during the inspiration? Sling fiber constrict the esophagus during the swelling. Sling fiber contributes significantly to the high pressure zone of the LES, and sling fiber transmit the intra-abdominal pressure to the GE junction. So how the sling fiber of gastric cardia contributes in the LES, right? So just remember that. What is a basic pathophysiology of GERD? So basically in body, there are two anti-reflex mechanism. Basically दो तरीकों से body reflex को बचा रही है. Number 1 is lower esophageal sphincter is a main factor which prevent the reflux from the stomach to the esophagus. Number 2 is spontaneous esophageal clearance. There is a peristalsis, there is a contraction basically which leads to anti-reflux. So these are the two mechanisms by which GERD doesn't happen. But if there is a failure, this leads to gastroesophageal reflux disease. So now I'm going to discuss in detail about the lower esophageal sphincter. हम LES के बारे में details में पढ़ेंगे. So basically, lower esophageal sphincter is a high pressure zone. It is not a distinct structure. Basically, distal esophagus के अंदर जो high pressure zone होता है, that is lower esophageal sphincter. It is not a distinct structure, right? So what are the component? What are the layers of the LES or how the LES work? So basically, a lower esophageal sphincter remain in tonic contraction throughout the period, except relaxes only during the swelling. This is very important. It will remain in tonic contraction it relaxes only during swelling. This is very important aspect of the lower esophageal sphincter, number one. Number two, sling fiber from gastric cardia to the lesser curve basically augment the lower esophageal sphincter. So basically, sling fiber from the gastric cardia are also contributing to the lower esophageal sphincter. And what are these sling fibers? These sling fibers of gastric cardia are basically continuation of the circular muscle fiber of the esophagus. This is very, very important, right? So we have discussed two components. There are four components. Number one, tonic contraction of distal esophagus continuous tonic contraction में रहता है. It relaxes only during swallowing, number one. Number two, sling fiber from the gastric cardia to the lesser curve also augment the LES pressure, and these are basically the continuation of the circular muscle fiber of the esophagus. So number three, diaphragmatic pleura around the esophagus constrict it during the inspiration, increasing the LES pressure. So this is the third component of the LES. Diaphragmatic pleura, which surround the esophagus, constrict it during the inspiration, increasing the LES pressure. Number four, firm anchoring of the gastroesophageal junction in the abdomen prevent spontaneous reflux. So these are the four mechanisms. Tonic contraction, number one. Number two, sling fibers. Number three, diaphragmatic crura, which constrict the esophagus in the inspiration. Number four, firm GEG anchoring in the abdomen, preventing the spontaneous reflux. These are the four components of the lower esophageal sphincter. Moving on, here you can see that these are the sling fiber, right? And this is the cardia, and this is the lesser curve. And this is the continuation of the circular muscle fiber of the esophagus. So these are the contributing into the LES pressure.